In the relapsed and refractory setting, the novel or next generation BTK inhibitors, I would say, we think of those in two main categories. There are the second generation covalent or irreversible BTK inhibitors. The ones that are approved in that are Zanubrutinib and Acalabrutinib. And now for relapse refractory CLL, after 2 lines of therapy, is also the non-covalent BTK inhibitor Pirtobrutinib, formerly called LOXO 305, which was just recently approved. In terms of how that changes the treatment landscape, I would say for relapse refractory CLL, predominantly we would still be favoring the covalent BTK inhibitors, so Zanubrutinib or Acalabrutinib, in those patients that have never had a BTK inhibitor before, or if they had first generation Ibrutinib, were intolerant, and now relapsing, then there are studies showing that patients safely may be able to tolerate the second generation covalent Acala or Zanubrutinib. For Pirtobrutinib, predominantly using this for patients after they've received a covalent BTK inhibitor and venetoclax-based therapy. There are important clinical trials looking at Pirtobrutinib, earlier lines of therapy, including clinical trials of frontline therapy. But in terms of clinical practice, until we understand, I guess, how non-covalent BTK inhibitors and resistance or post non-covalent affect the ability to go back and achieve a response to covalent, I'm not yet moving that ahead of the covalent BTK inhibitors. Retreatment with venetoclax, not just based on the abstract we presented, but in general and listed in the NCCN guidelines, I think is useful in certain circumstances. Patients with long remissions that may have specific reasons where they either didn't tolerate the covalent BTK or they had a toxicity that was severe, either in bleeding or cardiovascular, to which you feel that maybe meaningfully they would do better retreating with venetoclax after a period of remission, I think still also remains a possibility. And then, of course, how to maybe combine those in clinical trials or other novel targets in clinical trials. We still also favor considering all patients, especially with relapse refractory CLL, for clinical trials.